So let's transition to talk about a few other myxoid lesions, particularly myxoid neoplasms. So yes, so we're going to talk about a couple other myxoid lesions in the skin. And this is a paper that I wrote with my good friend and colleague, Dr. Nicole Riddle, who's also a soft tissue pathologist, about myxoid lesions in the skin. I feel like myxoid things are really confusing to people, particularly tumors, because they all look like spindle cells with blue goo in the background, right? And yet some of them are benign and some of them are malignant and some of them are locally aggressive. And there's a lot of differences there to sort out, and it can be quite challenging. So we wrote this paper with that in mind, that it's in diagnostic histopathology. I can send you guys a copy later for my residents here. And then also for those of you watching this on YouTube, after the fact, I'll put a link in the video description. You can download a preprint copy of this paper. Okay, so this basically kind of goes through and talks about a diagnostic approach to dealing with these lesions. Whoops, that was the wrong way. All right, and then we kind of have tables in the paper breaking it down that, you know, a lot of things are myxoid tumors that typically involve the skin. But then there are sometimes that you can have deep myxoid tumors that can superficially involve the skin, but they're usually deep, but sometimes they happen in the skin. And then there are other things that are only sometimes myxoid, but not always, but it's good to know about those. And then also things that have a chondromyxoid appearance are good to keep in mind, because chondroid and myxoid can, because they both look blue and kind of homogenized, they can really overlap. And sometimes it's hard to sort out things that are chondroid versus myxoid. All right, so here's an example of one of these myxoid lesions. Let's get this turned around here. So you can see this a multinodular mass that's got a blue myxoid appearance. And it's kind of, each of the lobules or nodules are intervened by this kind of fibrous bands or septae. If we go in closer, I think it stands out, these vessels. The vessels are branching, kind of these prominent branching blood vessels. And the vessels have a nice bland endothelium and a kind of a thin wall, but there's definitely still a vessel wall there that you can see. So it's important the reason I make a point about that is that a lot of times people see myxoid and then branching vessels, and the first thing they jump to is myxoid liposarcoma, because myxoid liposarcoma has the branching so-called chicken wire vessels. I have a liposarcoma video I'm working on. I just have not gotten around to finally recording it, but I'm close. That'll go over this in greater detail. But basically, the vessels in myxoid liposarcoma are branching, but they are super, super, super tiny. So much more thin than this. This is way too thick for the vessels of a myxoid liposarcoma. The myxoid liposarcoma vessels are basically like one endothelial cell thick and like single layer of red cells that can fit in between. The other thing is myxoid liposarcoma is vanishingly rare in the skin. It's almost always a deep soft tissue tumor. There have been rare reports in the subcutis. I've seen many, many myxoid liposarcomas. Never have I seen one in the skin or subcutis. So it may happen, but it's very, very rare. Okay, so that's not what this lesion is. But I just wanted to point that out because that's one of those things that people can get confused by the vessel pattern here. So these vessels are branching. We've got myxoid backgrounds, and then we've got some bland spindle cells scattered around in here. No significant atypia, and a couple of little scattered inflammatory cells, you know, kind of percolating through. So what name would you give to such a lesion as this? Does anyone have a suggested name for this entity? So I'm seeing angiomyxoma and myxoma. Okay, any other options? Those are both good. Okay, no takers. The answer is yes, both of those are correct. So this is, depending which name you like better, you can either call this a cutaneous myxoma, or you can call it a superficial angiomyxoma. Because in soft tissue pathology, we like to use like lipo, angio, fibro, and myxo, and then we just scramble those around and reuse them, and each of the different combinations means something totally different. So this is why people don't like soft tissue pathology, because the names are all confusing. But I actually like the name superficial angiomyxoma here because it puts in mind the fact that this lesion, when it's superficial myxoid lesion, they tend to have these prominent branching vessels, and I think that's a nice thing to know about. Deep myxomas, on the other hand, like intramuscular myxomas, usually do not have very prominent vessels. So it's kind of interesting. So when I sign these out, I usually say superficial angiomyxoma, parentheses, cutaneous myxoma. These are benign. They involve the skin and subcutis, and they they usually are sporadic. The ones that I've seen mostly have been, but there is a syndrome that they can be associated with in certain contexts. And what syndrome is that, where people have a tendency to get cutaneous myxomas or superficial angiomyxomas? Yeah, Carney syndrome or Carney complex exactly is associated with cutaneous myxomas. Now, the harder question, what particular anatomic sites do Carney's syndrome or Carney complex patients most likely get myxomas at? Yes, cardiac myxoma for sure. Cardiac myxomas occur in Carney's. But in the skin, there are 3 particular sites that when you see a myxoma in those sites, you should start thinking about Carney. I'm just watching the chat box here to see. So the ear, the eyelid, and the nipple. If those are 3 sites that for some reason tend to have a predilection in Carney complex, and then that's, sorry, I'm reading the chat box and getting distracted. Okay, those are the sites, the ear, eyelid, or area right around the eye, and then the nipple. Those areas, if I see a myxoma in those sites, I would usually say, hey, check this patient for Carney. Otherwise, there are the other features, cutaneous features that can be seen in Carney complex that might have already led the patient to get workup for that. These are benign, but they do have a tendency to recur locally. I don't think that they require aggressive treatment, but just know that if you excise one and it's got positive margins, there's a chance it'll grow back, but it's a benign thing. So if, I usually feel like as a general rule that benign lesions that have a chance for recurrence, but a non-destructive local recurrence, and that don't have a known risk of turning into malignancy, which most soft tissue things don't, like benign soft tissue lesions don't usually progress into malignant. That's very different from like epithelial lesions in other parts of the body where we have precursors. Most soft tissue lesions don't really have precursors that we know of. There are some exceptions, but in any case, this thing it can recur, but it's not going to come back and behave in an aggressive fashion. So the general rule I like is that for things that have a risk of non-destructive local recurrence, just watch and wait. And then, even if it's a 50% chance of growing back, 50% of the time, the patient won't get a recurrence. And then if they do get a recurrence, then you can re-excise it at that point. Now, obviously, you have to sort out between the dermatologist and the patient what the right situation is for that patient, the particular clinical scenario. Some patients might just feel better if they have something excised. So I always leave that open, but that's kind of the way I think about it. Because I think there's a lot of times where things get talked about and we say, well, this has a risk of recurrence. Well, yeah, I mean, a lot of things can recur. So that doesn't necessarily mean that you have to do aggressive surgery to remove them. So just my philosophical 2 cents about that. Here's another example. It's upside down. Let me turn it around. Better. So there's a skin up here. This one's centered mostly in the subcutis. Again, look at how lobular it is with that nice intervening fibrous septa. I really like that. That's a common finding, not always there, but often there. Again, kind of prominent vessels, not as nice and branchy as in the other case. And a couple things about this particular case, which is why I want to show you. What are these? There are neutrophils scattered in this tumor. So neutrophils are present, I think it's about 25% of cutaneous myxomas have scattered neutrophils in them. So you don't have to have them, but when you find neutrophils scattered in a myxoid lesion, you're probably dealing with a cutaneous myxoma, superficial angiomyxoma, whichever name you like. So it's a nice thing to look for. It's a kind of a cool little pearl. I don't know why this happens, but it's a thing. It's been described and I've seen it in several cases. So I think it can be a helpful finding when you have it, but you don't have to have it. And again, the main thing we want to see here is you've got a myxoid lesion that's not very cellular. Is there any significant nuclear atypia? That's the main thing you want to assess here, and we'll talk about why in just a minute. So that's the way the nuclei should look. They're bland and spindled. Sometimes they're kind of bean-shaped or reniform nuclei. That's totally fine. You don't want to see hyperchromatic pleomorphic cells, okay, in a myxoid lesion. If you see that, then you got to start thinking about some malignant options. All right. And the other thing that I'll point out in this particular example is this. Cutaneous myxomas have a tendency to involve adnexal structures, and that can lead to entrapment of sweat ducts or sweat glands and or hair follicles, and they can become cystically dilated. So here's a dilated cystic hair follicle. Look, you can actually see the hair shaft in there still. So it's basically made a follicular cyst in the middle of this lesion, and probably it's ruptured at some point, which has caused it to get scarred and fibrotic right around the edge of the cyst. But that's a relatively common finding. A significant subset of cutaneous myxomas will have adnexal structures, cystic structures in the midst of them. All right, so nice example again of cutaneous myxoma, AKA superficial angiomyxoma. Now, a question that comes up sometimes is, well, what about focal dermal mucinosis or focal cutaneous mucinosis? So how do I know when to call it this versus when to call it a cutaneous myxoma or something else? Well, I think it depends mostly it's how big and deep is it. If it's a tiny little thing and the dermatologist thought it was a little papule and it was a single little papule shaved off and all you see is an aggregate of myxoid or mucin in the dermis, then that is what I would call a focal cutaneous mucinosis. It's basically just kind of a descriptive term for a little pocket of mucin in the dermis. If it's got prominent vessels, if it's got neutrophils, now sometimes if this gets picked at or is ulcerated, it can get neutrophils, but or if it's the superficial aspect of a larger, deeper lesion, then those are times where I might think more about cutaneous myxoma. Again, both lesions are benign, so the distinction is not that important, but there are times where we wonder, well, how do you make the distinction? And people have asked me that, so that's the answer. I don't know if it's a very scientific or good answer, but it's an honest answer. That's how I decide. If I just think it's a tiny, small lesion, like here, you can see this thing has got even a little collarette. It's just a tiny little pea size or smaller nodule of mucin here. So that's focal cutaneous mucinosis. And obviously, you don't need to necessarily do a colloidal iron or other mucin stain, in this case, just done for teaching purposes, which you can see how beautifully it highlights. But usually, my thoughts are this, on colloidal iron and mucin stains. Sometimes people ask me about this too, so it's confession time. I feel like when I can tell that there's enough mucin there by looking at it, that if I do a colloidal iron, it's going to be gorgeous and look great. But I don't really need the stain when I can see the obvious mucin. If, on the other hand, the mucin's so subtle and I'm not really sure if it's there, well, if I go do a colloidal iron, guess what? I'm going to find a little bit of blue. If you want there to be mucin, do a colloidal iron. There will be something that turns blue in the dermis, and you can call it mucin. So, I mean, I'm being a little bit facetious, and I know some people who like to use those stains, and I do occasionally use them. It's true. But I think that's kind of the thing, is that I feel that the times where I really need the stain is the time where it's not going to necessarily help me that much. One exception would be that sometimes mucin, it tends to wash out on a recut slide on an H&E. It's one of the first things I feel like to start fading with time. Mucin that looked blue when the stain was first made and the slide was cut, you might look at it a few months from now and it's already starting to fade. So when I go look at my recut collection, I find that all my mucinous things tend to be, the mucin is like totally turned clear. So in those cases, just recutting an H&E can help. But if you want to, you can also do a mucin stain if you need to enhance the appearance. Oops. And then this, on a similar vein, is a little pocket of mucin in the dermis. Quite a bit like what we just looked at with focal cutaneous mucinosis. The big difference here, of course, is where it's located. We're on acral skin, and particularly on the proximal nail fold right there, where the skin, for the pathologist here, proximal nail fold is where the skin is on top of, where it abuts the edge of the nail plate right there. And so these lesions are a little pocket of mucin that arises there and almost always fills the dermis, like up into the papillary dermis, and pushes up into the epidermis, pushes the epidermis upward over top of it, and thins out the epidermis oftentimes, okay? There are two different patterns, I think, that you can see with digital mucous cyst, okay? One of them is like this, where you actually can see a cystic space with blue mucin filling that little area and making a pool inside. And the cyst is not really a real cyst. It's not lined by anything. But it's got kind of a well-formed fibrous wall, just without no epithelial lining, but it's got a well-formed fibrous kind of wall that's around it, okay? So that's one pattern. The other pattern, and probably the more common pattern in my experience, is this. What happens is that the mucin has seeped out and leaked out of the cystic space and filled the dermal collagen around it and kind of intermingled, and it's left it very loose. See how loose it is? It's kind of loose, a little bit of spindle cells in there. It's kind of filled up and puffed up and almost made this kind of edema pattern. And here that you can see that the mucin's not quite as blue, it's kind of washed out and faded over time. But this pattern of very loose collagen with spindle cells forming a pocket underneath the epidermis in this site, that's digital mucous cyst, okay? So even if you're like, well, I don't see the cyst, that's okay. It can look like a little, kind of almost like a little tiny myxoma. That's a totally common pattern. And to me, this is analogous to what you see in a ganglion cyst. And people debate over whether these are really like ganglion cysts or if they're different, if this is actually mucin or synovial fluid that's seeped out of the joint space. Some people say that by definition, it shouldn't be that. I don't know. Whatever you want to believe is fine. I don't really know the right answer or care. All I know is that this is a benign thing and it arises there. And if I can make the diagnosis, then some days I have to be okay with the fact that I don't know all the answers. So the point is, though, that in ganglion cysts around larger joints, like around the wrist or the knee, you can see well-formed fibrous lining with mucin or synovial type fluid inside. And then also you can see in the collagen around it, this pattern, this loose edematous pattern. So I feel like there's a nice analogy there that you can see both of these patterns in digital mucous cysts, just like you can see both of them in ganglion cysts near joints. Now let's talk about, this is, I know, a little unfair for the dermatologists here, but for the pathologists, let's talk about the deeper form of myxoma, intramuscular myxoma. Intramuscular myxoma, like the name suggests, is a large deposit of myxoid material with some bland spindle cells, and it's in the middle of a deep muscle. And what it does at the edge is very characteristic. Wait for it to come into focus here. Oh no, is it not? Oh, that's why it's not focused. It's not a digital slide. I'm sorry, I forgot that I didn't have a digital slide handy, so I just used a PowerPoint slide. So in any case, you can see that the muscle is splayed apart here, and this is very hypocellular and blue. And the question that we ask when we see a myxoid lesion in the deep soft tissue, the first thing to think of is, of course, intramuscular myxoma. But so the questions you have to decide are, is it hypocellular? Is it hypovascular? And does it have bland nuclei? And if you can say yes to all of those, then there's a good chance it could be an intramuscular myxoma. But if you say no to one of those, then you've got to stop and consider other options. If there's atypia, if there's increased cellularity, and if there's prominent vessels in a deep myxoid lesion, those should make you consider other things aside from intramuscular myxoma. The reason that I bring this up is because there's a tendency, I think, when you see something that's real myxoid and it's down deep, if you don't notice real obvious malignant features, myxoma is the first thing that people think of. And I've seen on multiple occasions, actually, where people have misdiagnosed things, deep masses particularly, as myxoma, and they ended up being something else, and oftentimes something else malignant that they just weren't as familiar with. And so I think it's an important pitfall to know about, that these are the kind of general rules that I go through in my head, that if any of those things aren't true, then I have to stop and think, I don't know about the idea of myxoma. I bet this is something else. And like we already talked about, cutaneous myxomas, of course, do have prominent vessels, but they shouldn't have atypia and they shouldn't have really cellular areas. So closer look at the case we were just looking at. This is back to the intramuscular myxoma. This is very hypocellular. There's a few thin vessels here and there, but really not very prominent. There's no areas of hypercellularity aggregating together. And look at this splaying apart of the skeletal muscle fibers. That's totally normal and expected for intramuscular myxoma. That is not invasive infiltrative growth, okay? It's the same as true as intramuscular lipomas. They do the same exact thing. They spread apart and splay apart the skeletal muscle fibers. And that could look scary at first if you're not familiar with it and make you think, oh, this is an invasive infiltrative thing. Remember that in soft tissue pathology, infiltrative and invasive, like we use when we're talking about, say, carcinomas or epithelial tumors, the same rules do not always apply. Spindle cell mesenchymal tumors often grow in a circumscribed fashion, but sometimes they're very intermingled with their surrounding environment, and that does not necessarily mean they're malignant. So we can't use circumscription depending on the context, but you can't, as a general rule, use circumscription to tell you if a soft tissue tumor is benign or malignant. Sometimes that works in certain entities, but definitely not always. There are plenty of times things that are circumscribed are totally highly malignant. For example, a lot of high-grade sarcomas are very circumscribed because they grow so fast they push everything out of the way. And there are plenty of benign things, like intramuscular myxoma, that look very infiltrative at the edges but are totally benign. And there's a closer look, the cytology of intramuscular myxomas. And you can also see the similar cytologic features in cutaneous myxomas, is you tend to either have spindled or kind of bean-shaped reniform nuclei. And they often have this little blob or pot belly, as Mark Edgar, one of my soft tissue mentors, loved to say, this kind of pot belly of pink cytoplasm. And I think these bellies of, or I think he just said bellies of cytoplasm, but for some reason I like the idea of pot bellies better. And so I morphed it over time in my memory. But Mark Edgar always came up with these really great visual analogies in soft tissue pathology, and I've retained and continue to teach so many of them. So this is an example of that. Let's get a closer view of the little bellies. See that little blob, that belly of cytoplasm here? It's not quite as well formed, but this is a really nice little tip that you tend to see in myxomas. You don't have to have it, but when you find it, it's very satisfying, I think. So that's a good example of the kind of bean-shaped nuclei with the bellies of cytoplasm from myxoma. Does anyone know, while we're here, what syndromes can you get intramuscular myxomas in? Yeah, Mazabrod syndrome, very good. Yeah, and so Mazabrod syndrome is is a polyostotic fibrous dysplasia plus myxomas, intramuscular myxomas. Okay, good job. Now, here's another lesion. Is it hypocellular? Yeah, pretty hypocellular. Myxoid, yeah. We don't really see prominent vessels, but like we already talked about, myxomas in the skin can have prominent vessels. There's nice kind of fibrous septa between different lobules. But if we zoom down, there are scattered cells that are very atypical, hyperchromatic and pleomorphic. And if you look around throughout, there's more and more of these the more you look. And you don't have to go down to high power to see, like, look from here. Look at that big dark thing there. We go look closer. What is it? It's kind of multinucleated, but there's some atypia in here. So usually the atypia in these lesions will stand out to you. You don't have to be, you might not see it at 2x magnification or 2x objective, but it doesn't take much looking around to say, ooh, there's some atypia there. I don't like that. Like, look at that guy. Atypical mitotic figure, right? So if you look around, if you're lucky and have a big enough sample, you'll even see mitoses and atypical mitoses. But a lot of areas kind of closely resemble myxoma. So you could get in trouble here if you weren't familiar with this. And in addition to the atypia that we see scattered around in here, we also begin to see focal areas like this that are more cellular, right? Not solid sheets of cells, but certainly we see cells that are clumping up and aggregating together. And that's something that I don't usually like to see in myxomas. And in these areas, you can see, again, the atypia and the clumping of cells together. So what is this entity here? Okay, I see a taker, yes. This is Myxofibrosarcoma. And this is a grade 1, I would say. These areas right here may be starting to approach grade 2. I guess you could say like it's somewhere between 1 and 2. Grading of myxofibrosarcomas is a bit subjective, but this is on the lower end of the spectrum, certainly not a high-grade lesion. So myxofibrosarcomas are important for dermatologists to know about too, and anyone who does dermatopathology. And the reason for that is that they have a tendency to involve the skin and subcutis. About half of cases occur above the fascia. Okay, they can also arise in the deep musculature too, but about half of the time they're either going to be coming up from deep and involving the overlying subcutis and dermis, or totally centered in the dermis and subcutis like here. So that's one reason. Because of that, they can present to the dermatologist as a cyst, And as my residents know, and as my new soon-to-be residents at Geisinger will soon know, I love to harp on the fact that everything is a cyst clinically until it's not a cyst. Because I can't tell you how many things I've seen that were called cysts that ended up being some weird sarcoma or nexal carcinoma. Anything that's a deep nodule like this is going to look like a cyst clinically, and cysts are common. So of course that's what people are going to think. But that's the reason that we have to, sample things and biopsy things to find out for sure, because there's plenty of things that look like a cyst that are not. So I've seen these come in thought to be cyst among the many other things that I've seen that were clinically thought to be a cyst. So this is an important lesion because it can be superficial. It tends to occur on the extremities of older people. And one of the important things about it is it is very infiltrative. And so it's not, the infiltration is not what makes it malignant, but the infiltration in this case, because it is malignant, is what causes the problem. These tumors have a real high risk of local recurrence. They can be quite aggressive locally. And even when you get a big excision and try to get a wide margin around them, sometimes they're still present at the margin. This is a perfect example. This was taken out by a sarcoma surgeon who knew what the diagnosis was. So they weren't messing around trying to just shell it out. They were trying to clear this tumor and thought that they were around it. And this was done by an experienced sarcoma surgeon. And yet still the margin ended up being positive because look, the main lesion, the mass is here, but watch how it trickles all the way out, all the way to the ink. I'll go closer and show you. We already talked about this area. This is malignant. You can still see atypia here and here. And as we go out, there's more. The myxoid and the atypical spindle cells continue to trickle out and out and out. And that's a very characteristic growth pattern for myxofibrosarcomas, is they tend to track along the fascia and along in between the subcutaneous septa. And so that's a very characteristic growth pattern, that they follow these planes in between the tissue, the different layers of tissue, and they just track and trickle along there. And they often extend quite a ways beyond where the mass appears to end clinically or on palpation. So sometimes if you get imaging studies early enough, they can see this and they can see the very characteristic infiltrative growth pattern. But much more often, I end up seeing these after they've already been biopsied, thought to be a cyst or something else, or a lipoma. And then once the pathologist looked at it and realized, oh, this is a sarcoma, then they got sent and referred for excision. So a lot of times we don't end up having preoperative imaging studies on these because no one expected at first for it to be a sarcoma. And so imaging was not done. So that's a good example, though, of the low-grade end of the spectrum of myxofibrosarcoma. And these are the ones that can indeed mimic myxomas, and it's really important to keep them in mind, particularly when you're dealing with tumors that are myxoid on the extremities of elderly patients. They're very uncommon in young adults, and I've never seen one that I believed was this in a kid. It's been reported, but I have reservations about believing those reports. This is almost always a tumor of older adults. And then here's a couple other, that's just what I basically told you. And yeah, basically the higher grade end of the spectrum here is more or less like a myxoid form of undifferentiated pleomorphic sarcoma. So UPS, which is a high-grade sarcoma in adults that doesn't have any line of differentiation. That used to be years ago referred to as malignant fibrous histiocytoma, or MFH. And as I hope you all know by now, that name is completely obsolete and should never be used in modern pathology. Okay. So a couple more pictures of that. And this is a more dramatically atypical one. Very ugly cells, myxoid background. These long, curvy linear vessels are very characteristic. They're not always present, but they're often there. And that's a really helpful find, these long, prominent vessels with ugly cells. And the cells have this tendency, see, here's a long vessel, and it kind of gently curves as it goes. And the cells in myxofibrosarcoma like to clump and aggregate around the edges of those vessels. So that's why I find that really helpful. If I see vessels and I see aggregation of cells around vessels, that's where I go and look closer. Those are the areas I focus on when I'm looking for atypia, to make sure that I'm not missing a myxofibrosarcoma. Although here, you're not going to confuse this with a myxoma, because look at how cellular it begins to get up there. No way is that a myxoma. And then in the high grade end of the spectrum, grade 3 myxofibrosarcomas, you get areas that have sheets of ugly cells with ugly mitoses and atypical mitoses and massive pleomorphism. And those are clearly, they look basically just like a UPS or other high grade sarcomas. So if I see high grade sarcoma like that, and then pockets of stuff that are myxoid and look like this, those I'll call a high-grade myxofibrosarcoma or myxofibrosarcoma grade 3. And those tend to behave similar to other high-grade sarcomas. The very low-grade, grade 1 myxofibrosarcomas usually do not metastasize, but they tend to grow back relentlessly sometimes if they're not widely cleared surgically. And when they grow back, they can progress and become higher grade over time. I've seen one that was started out as a grade 1 and then recurred once or twice over about 10 years and finally ended up becoming grade 2 and then grade 3, and it progressed onwards. So that is a problem. But when they're low grade and superficial, they don't tend to metastasize. When they're high grade, they tend to behave more or less like other high grade sarcomas, a slightly lower likelihood of metastasis, but still a totally malignant tumor that needs to be treated very seriously. And I think that is the end. And I just was going to point out to you, I wasn't delving really deep into that because I've already covered myxofibrosarcoma and the not look-alike but sound-alike low-grade fibromyxoid sarcoma. And I've covered those in 2 full-length videos. So if you want to know more than you ever wanted to know about either entity, it's on my YouTube channel. And in addition to that, I have a short video for those of you who just need to get the basics so that you can take your boards. You can watch this, and it's, I think, like 5 minutes, and it explains real quick how to tell apart low-grade fibromyxoid sarcoma from myxofibrosarcoma. It sounds very confusing, but I promise you, once you watch this video, you should be able to master it with no problem. In the vast majority of cases, they really look quite different from each other. They just are named frustratingly similar to each other.